Frozen shoulder or adhesive capsulitis is a very unique and painful condition that involves immunological changes inside the shoulder joint, which lead to a deposition of irregular collagen tissue in the capsule of the shoulder joint. This is associated with pain and stiffness that rapidly worsens over a few months, stabilises over a few more, and then gradually resolves over several more months. The shoulder is a complex ball and socket joint that allows full range of movement of the arm. It offers this wide range of motion, but at the expense of stability and potential injury risk. The capsule of the shoulder has layers of collagen tissue that stabilise the shoulder joint at ends of range, and it has an inner lining that produces a thick lubricating fluid called synovial fluid. This capsule in the shoulder normally has some extra slack down the bottom. This area we call the inferior glenohumeral ligament. But instead of it being thin like a plastic bag, this tissue becomes thick and leathery, which creates stiffness and quite severe pain, often radiating down the arm when the tissue is stretched in the early phases. It's thought that this process is triggered by an immune response, as I've mentioned, which then leads to infiltration of fibroblasts that lay down excessive collagen, and that creates the stiffness, while chronic inflammatory cells and new blood vessels growing into this thickened capsule are thought to be responsible for the marked pain that we observe. Now, while a frozen shoulder can often be associated with other conditions and it can take some time to announce itself, the hallmarks are severe pain, often radiating pain, and the development of stiffness where rotation range of motion is the first range lost. Shoulder pain normally begins over a few months, and over about 6 to 9 months there's generally a marked loss of range of motion. There are a few phases, each lasting 6 to 9 months, and rarely the overall course can last 3 years, but the prognosis is generally good. In the freezing phase, the patient develops a slow onset of pain, the pain worsens and the shoulder range of motion comes down. In the frozen phase, the patient experiences a slow improvement in the pain, but the stiffness remains. Then in the thawing phase, the patient slowly regains full mobility of their shoulder and returns gradually to normal without pain. We aren't entirely sure why frozen shoulder occurs. However, it's more likely to occur in patients who've recently had to immobilise their shoulder for a period after trauma, such as surgery or a fracture. And there's also an association with autoimmune conditions, such as thyroid conditions like Hashimoto's or Graves' thyroiditis, type 1 diabetes, celiac disease and pernicious anemia. These fall under what we call the thyrogastric cluster. The strongest association is type 2 diabetes as well as insulin resistance. Frozen shoulder is also associated with heart disease and cardiac surgery, as well as Parkinson's disease and breast cancer, particularly post-surgery. Frozen shoulder tends to cause a background of dull, aching pain, with sharper shoots of pain occurring with sudden movements, particularly down the front and side of the arm. There's a clear lack of mobility that's seen, especially the loss of rotation, and later on, patients lose elevation range of motion. The diagnosis of frozen shoulder can be a little bit tricky, and as I've mentioned, it can be a bit delayed to present itself. Often, the first physical examination finding is the loss of rotation range of motion. But other important contributors also need to be assessed on examination because it can occur with overlapping issues such as osteoarthritis, rotator cuff tears, impingement syndromes, and diabetes. Comprehensive consultation needs to include a history, examination, and possibly a point-of-care ultrasound to thoroughly assess all of these potential contributors. Further testing may include x-rays to look at any bony abnormalities or other issues in the shoulder such as osteoarthritis. MRI provides high-resolution panoramic detailed images of the soft tissues, and an MRI can produce cross-sectional images of the internal structures if the diagnosis is at all unclear. Ultrasound has the advantage of being a dynamic test that can allow us to examine the shoulder during movement at the time of consultation. One key finding of a frozen shoulder is increased blood flow and tissue thickening around the top of the biceps tendon in an area that is called the rotator interval. While not all these approaches or tests are required to confirm the diagnosis, this diagnostic process allows us to review any possible risks or pre-existing conditions that could affect recovery and treatment options. The treatment for frozen shoulder. Frozen shoulder generally improves over time without any intervention. However, it can take an average of about 2 to 3 years. If the symptoms are severe, affecting sleep quality, and are not controlled by physiotherapy and judiciously prescribed medication, escalation to corticosteroid injections is entirely reasonable. Steroid or corticosteroid or cortisone injections have been shown to be effective for pain in the early phases of a frozen shoulder for reduced pain so that patients can sleep at night in particular. The location of the injection seems to be very important, and we know that bursal injections do not work for capsulitis related pain. So these injections are delivered to the shoulder joint via the front, the rotator interval, and sometimes through the back via a posterior approach. Hydrodilatation or high volume injections have no strong evidence of being superior to cortisone injections, but they may assist in the return of range of motion, particularly in the later phases. Physiotherapy, especially after the painful phase has settled, is useful to maintain rotator cuff function and to restore strength and range of motion. Now, surgery for a frozen shoulder is controversial. It's a last resort, but it has been shown to improve range of motion significantly. However, most surgeons do not like to operate in the early stages before the condition has stabilised, as surgery is a known cause of a frozen shoulder. And it's thought that the trauma of surgery can then stir up this immunological stimulus to actually make the pain and stiffness worse. Therefore, patients tend not to be offered surgery while they're in the freezing phase.
I hope you found this video useful. I create these educational videos to help empower patients by allowing them to understand their problem, treatment options, and the expected recovery. Please remember, this lecture is for educational purposes only, does not constitute the giving of medical advice, and no patient-doctor relationship is formed.